everyone. Thanks for coming. Macrophage activation syndrome is one of the conditions which I think is fairly underdiagnosed. And anytime I've seen a case of macrophage activation syndrome, there have been multiple complications. Those patients, some of those patients did not have a good outcome, and time is of the essence in these patients. If you diagnose them early, if you treat them early, outcome changes a whole lot. So that's why, and it has multisystemic involvement, and many subspecialists will get to see macrophage activation syndrome in their life, and we're going to talk about it, and I want you guys to be aware of it, so you start thinking in a patient who is very sick, who has multi-organ dysfunction, and we'll get started now to talk about macrophage activation syndrome. Can everybody hear me well? Okay, good. So objectives of my talk is that you should be able to define macrophage activation syndrome by the end of this talk. I also want you to know what is the difference between hemophagocytic lymphohistiocytosis or secondary HLH, which is sometimes used synonymously as macrophage activation syndrome, except macrophage activation syndrome is the terminology used when this condition happens in the setting of rheumatology problems. We will describe the clinical features of macrophage activation syndrome, and we need to recognize those patients who have macrophage activation syndrome and design an appropriate evaluation and management plan. I have no conflict of interest to disclose. I'm going to start with a case. This is a case that I saw 3 years ago. A 15-year-old African American female with known past medical history of hypertension presented with 2-week history of intermittent high-grade fever, Tmax of 104, and pleuritic chest pain. Her exam was remarkable for tenderness of the wrist and maculopapular rash on the upper arms. Her lab showed that she has elevated SEDRATE and CRP, leukocytosis, anemia, and thrombocytosis, and had negative ANA and rheumatoid factor. She was found to have acute pericarditis. Her echo was normal except a trivial pericardial effusion. She was initially treated with aspirin and colchicine for the pericarditis. Her pericarditis improved, but she continued to spike fevers. At that time, rheumatology was consulted because she has recurrent fever and is not getting well. When I get to see the patient, recommendations were made to obtain LDH, triglyceride, and ferritin. Her LDH came back elevated at 569 with the range between 84 to 246. Her ferritin was markedly elevated. You can see it's close to 50,000. And at that time, I started her on high-dose oral steroid, and her fever resolved. But this fever recurred in 2 days, and fever pattern changed. She was initially just getting spiking fevers, and now fever was persistent. It was not breaking. She was also found to have an abrupt drop in the ESR. She had low fibrinogen, and she developed a profound hepatic dysfunction and failure. And her transaminases were as high from 5,000 to 7,000. This patient was transferred to ICU, and there was a consideration at this point that this patient has what is called macrophage activation syndrome or secondary HLH. So macrophage activation syndrome, we'll start with the introduction. We'll discuss the classification. We discuss the history about this disease, pathophysiology of the disease, what are the salient clinical features, how do you diagnose those patients, and what would you do to manage them, especially managing early, and at the end we will summarize what are the challenges related to this disease. So macrophage activation syndrome or even secondary HLH is a condition in which there is uncontrolled systemic inflammation, and it's driven by lymphocytes that activate the macrophages. Coming to classification, primary HLH. So a syndrome exactly like that can present in people who have defective innate immune system, and it present at very young age, in infancy, in young children, and that's called primary or familial HLH. First case of familial hemophagocytic reticulosis was first described in 1952. So the history dates back in 1940s to 50s. Secondary HLH, which is also called acquired or sporadic HLH, is used to describe those people who have this syndrome, but they do not have a known genetic mutation. And in them, there can be a trigger, which has made this immune system to have immunopathologic state. the most important triggers that we have to keep in mind is viral illnesses, malignancies, as well as rheumatic condition. When this condition happen in the setting of a known rheumatology problem, my job is easy, and diagnosing these patients early and treating them is relatively easier because we recognize it. And then those patients usually are juvenile idiopathic arthritis. And I need to show you that it's not all cases of juvenile idiopathic arthritis which develop macrophage activation syndrome. There is a specific subset of patients which are at risk of developing that. And after we discuss the pathogenesis and see why a specific subset develops that, you will see those patients are markedly inflamed compared to rest of the cases with juvenile arthritis. And in the setting of rheumatology, these cases are called macrophage activation syndrome. Going back to the history of that, the first case of HLH was described in 1950, and that time there was a feeling that it could be familial or sporadic. In 1970s, we started recognizing what are the triggers of this disease. That could include viral infections or malignancies. So apart from familial form, for acquired form, we started knowing what are the triggers of the disease. In 1980s, the term hemophagocytic lymphohistiocytosis was coined. And in 1994, a definition was agreed upon after the conduct of an international trial. And in that, there were 5 criteria, and I will show you HLH criteria. They have been revised. So the first criteria were in 1994, and in 2004, there were 3 more criteria added. So there are 5 criteria initially described in 1994, and 3 were later added in the 2004 trial. In 1999, the first gene defect in those patients who have familial HLH was discovered, and there's a mutation in the gene called PRF1 or perforin. Going to pathophysiology of this disease, what happened, why these patients are so sick? So there are definitely multiple immunologic abnormalities in these patients. They have excessive inflammation and they have tissue destruction. It's happening because of the abnormal immune activation. 2 cell types which is involved in the pathogenesis include macrophages. Job of macrophages is that they take the antigen, it can be a foreign antigen, it could be a damaged host cell, and they present it to lymphocyte. And then they also excrete quite a bit of excessive cytokines or pro-inflammatory cytokines. And macrophages are trying to kill those cells which are not needed by body anymore. And natural killer cell and cytotoxic lymphocytes, when they get those damaged, stressed, or infected host cell through the macrophages, they do this perforin-dependent cytotoxicity in which they punch the hole in the wall of those macrophages and those host cells and basically destroy them, and that's why the immune system does not get overactivated. In patients who have familial HLH, there is a genetic mutation that they don't handle this process well, and the patients who have acquired secondary HLH or macrophage activation syndrome, they tend to have a trigger in which there is uncontrolled inflammation, and that led the immune system to go into a pathologic state. So in HLH or MAS, this natural killer cell and cytotoxic lymphocyte fail to eliminate these activated macrophages. Few words on perforin-dependent cytotoxicity. So normal elimination of activated macrophages is done by natural killer cell and by cytotoxic T lymphocyte, and it occurs through this process of perforin-dependent cytotoxicity. In this process, this natural killer cell and lymphocyte lyse the target cell in a series of steps that include formation of a immunologic synapse. There is a fusion of membrane of the natural killer cell and cytotoxic cell with these activated macrophages. They create a pore in the membrane of macrophage, and then they deliver these cytolytic granules into the macrophage. So the patient who have genetic mutation, they cannot do that. And the conditions which have been described, luckily many of them are autosomal recessive, not dominant, and some of them are X-linked. And when do you start thinking that patients have a genetic predisposition to this condition is when they have recurrence, when they present at a very young age, and when they have HLH in the other family members, and these are the patients who will actually need the stem cell transplant in future. Gene mutations which have been discovered now and I will show you a table later, the mutations which are commercially available to check. I want you to pay attention that PRF1 is most common in African American, and MUNC13-4 is more common in Caucasian. But you can see there are other genetic mutations which have been described. This picture is just trying to show you that at multiple levels at the perforin dependent cytotoxicity, different genes are involved, and if these genes are mutated, these patients are much more at risk of developing the secondary HLH or macrophage activation syndrome. Cytokine storm. So when these patients have this persistently active cytotoxic T cells, natural killer cell, and macrophages which are not being removed, they will cause excessive pro-inflammatory cytokine production, and those cytokines are the reason the patient is getting so sick, and this will cause multi-organ failure and high mortality. The pro-inflammatory cytokines which have been implicated are interferon gamma, tumor necrosis factor alpha, interleukin 6, 10, 12, and soluble IL-2 receptors. And soluble IL-2 receptor is something, this is the level you can check in the blood, and if it is elevated, you start thinking of the patient has possibility of macrophage activation syndrome. And other important thing that you want to look and make a definitive diagnosis is hemophagocytosis. So what these activated macrophages start doing is that they start engulfing the host blood cells. So patients start developing bicytopenia or pancytopenias. So they can have a worsening anemia, they have leukopenia, they have thrombocytopenia. And you can ask for biopsy of the immune tissues, which can be lymph node, which could be spleen, which could be liver, or bone marrow, and you will see that these patients have these hemophagocytes in there, and that's how you can make the diagnosis in the time when there is a need or a challenge to make the diagnosis. This is a slide showing hemophagocytosis, and these are the activated macrophages, and you can see it has started engulfing platelets and RBCs and WBCs in a patient bone marrow, and this is a child in which who has this hemophagocytic syndrome secondary to Epstein-Barr infection, EBV virus infection. So now let's come to trigger. This is the most important point to know about, that secondary HLH can happen in the setting of so many conditions, and we need to identify those. So starting with infections, you can see so many viruses have been implicated that patient can develop secondary HLH. That include EBV, CMV, HSV, adenovirus, parvovirus, varicella zoster virus, measles, H1N1, influenza, HIV, most of the viruses that we all know very well. I have also read reports about human metapneumovirus causing that. Different bacteria have been also implicated, including Brucella, gram-negative bacteria, tuberculosis, different parasites and fungi. So infection can be a trigger of HLH or secondary HLH, and I feel those patients are more challenging to diagnose because they do not have a known rheumatology condition in the past, so that we can think that they are at risk of developing this syndrome. Malignancy, so many kind of tumors these patients can present, that can be their presenting feature. So those patients can have leukemia, lymphoma, this could be myeloid malignancies or even solid tumors. And if you start reading literature on secondary HLH, I guarantee you most of the literature you will get is from pediatric oncology literature, because they get to see those patients a whole lot. Coming to rheumatology trigger, and that's where my job is today, to make clear that in what conditions in rheumatology I suspect patient will develop macrophage activation syndrome. So lupus, systemic lupus erythematosus is the first condition in which patient can develop secondary HLH or MAS. Problem with lupus patient is these patients have cytopenia as part of their own disease. They can have hepatic dysfunction as the part of their disease because they can have autoimmune hepatitis. So they are relatively challenging patient to diagnose too. But again, when you are in a bind and you are considering the patient has MAS, you want bone marrow biopsy. You want to look for that hemophagocytosis. Other things that help, because we will see ferritin is markedly elevated in patient with macrophage activation syndrome. And ferritin is not elevated in patient with lupus. As part of their disease, as part of their flare, we do not see marked elevation of ferritin. Other condition is systemic onset JIA that we're going to discuss next. And in juvenile arthritis, there are 6 subtypes. And systemic onset JIA is the only subtype in which patients are at risk of macrophage activation syndrome. The adult variant of that is called adult onset Still disease. And they also have a risk of developing macrophage activation syndrome and Kawasaki's disease. Immunodeficiency syndrome, something that I won't be discussing a whole lot in my talk, but I want you to remember that patients with defective immune system, it can be autoimmunity or it can be immunodeficiency. And all these syndromes which I mentioned here, including Griscelli syndrome and Shidak-Higashi syndrome and chronic granulomatous disease, many of these syndromes sometimes present as HLH part of their flare, and we need to be aware of that. I'm just going to take 1 minute to show you classification of arthritis in childhood. Because when we start talking about macrophage activation syndrome in juvenile arthritis, I want you to know which side of table you want to look at. So you know that oligo-GIA, including POSI, psoriatic, and enthesitis-related arthritis patients, they are non-inflamed patients. They do not usually get uncontrolled inflammation triggering MAS. Patients who have polyarticular GIA, seronegative patient, RF negative poly can be non-inflamed, but RF positive poly patients are usually very inflamed. But they have a typical pattern. They exactly look like adult rheumatoid arthritis patient with bilateral MCP and PIP swelling. And those patients also do not tend to go to MAS. So that this last category left here, systemic GIA. And as the name depicts, is called systemic onset GIA. Patients have systemic feature and then they develop arthritis. So that's the condition in which you see much more risk of development of macrophage activation syndrome. So a few words about systemic onset juvenile arthritis. It can present at any age, and it is the other name for it is Still's disease. It presents in old patients, and then it's called adult onset Still disease. In pediatric population, it's called systemic onset GIA. There is no sex predilection. It can happen in any sex, and it seems to be more common in Caucasian than African American and Hispanics. And typical patient is usually a child who keep getting fevers. These fevers are somewhere between 102 to 106. There is a daily spike of fever, and it comes at a set time of day. It may have a quotidian pattern or a double quotidian pattern. At the time of fever, these patients get these non-specific evanescent salmon color rashes, and they initially present. This is the presentation of these patients, and then they will have later development of arthritis. All the features that they have, these features are very confusing with infections and with malignancy. But chronicity of symptom help us decide to diagnose these patients, because infections do not go on to keep these symptoms, at least the typical infections, for 6 months or a year. That's what usually these patients are presenting with. So they have high-grade fever, daily spike, and fever curve help. If you make a fever curve, you know that patient gets the fever at the same time of the day. They can have lymphadenopathy, they can have pericarditis, they can have hepatosplenomegaly, they have this rash which usually comes and goes, and most of the time is more prominent at the time of fever, and then they develop arthritis. So this is the Still's rash, and this is a boggy arthritis that has developed in a patient later in the disease. If you look at their lab, they have leukocytosis, they have thrombocytosis. Their anemia of chronic disease usually doesn't go beyond 9 or 10 of hemoglobin. They can have a hemoglobin of 7. Cells are too inflamed to take iron. These patients' ESR is markedly elevated. Their ferritin is high, and it's in few thousands, not many thousands, which you see in patients with macrophage activation syndrome. Their ANA is negative. Their rheumatoid factor is negative. This is just one diagram showing you that these patients have IL-1 upregulation, and that's why all those lab abnormalities that you're seeing are there, and fever is there. Because what IL-1 does is, but it's upregulated, it goes and work on the hypothalamus at the thermoregulatory center to cause fever. And then it can also go act on the bone marrow to drive the leukocytosis, thrombocytosis, and then it will go through endothelial cell and cause the formation of IL-6, which goes act on the liver, and the acute phase reactant like SED-rate and CRP get elevated. So this is a research picture which is basically showing that this red thing is upregulation of the IL-1 in patients who have, this is gene sequencing in patients with systemic GIA, showing that IL-1 is upregulated. How do you treat those patients? You treat them with non-steroidal, which is the first line treatment, and they benefit from IL-1 antagonist therapy, anakinra. And that is the medicine which is used in patients with systemic GIA even at the setting of macrophage activation syndrome, because the theory is that these patients are having uncontrolled inflammation which is driving macrophage activation syndrome. In some centers steroid is used when there is no availability of anakinra, but that is the old school way of treating patients with systemic GIA. So this is just a picture showing the bars which are less red are after anakinra treatment, that IL-1 signature goes down with treatment in patient with systemic GIA. So systemic GIA patient 50% remit in first year. Best prognostic indicator is joint and platelet count at 6 months. 25% can have severe unremitting arthritis. And systemic manifestation usually burnout. Why do we care about all those things? Because if you think a systemic GIA patient is going to go into macrophage activation syndrome, these are the patients who still have systemic features, not the one which have burnout disease and now just have arthritis. So when patients have ongoing inflammation with systemic GIA and it's not controlled well, they are at risk of developing macrophage activation syndrome. And it can happen in these patients with viral infections, flares, change in the medication, and it can be spontaneous. So when these patients develop macrophage activation syndrome, their spiking fever change to persistent fever. Their anemia start worsening, their thrombocytopenia, they develop thrombocytopenia. I think the word of caution I want to use here is these patients have very high white count and very high platelets. So when they start developing MAS, they become normal. So human tendency is to feel happy that something looks normal, but that may be actually a storm coming when they start developing this relative leukopenia and thrombocytopenia for them because they are developing macrophage activation syndrome. So if a patient with systemic GIA develops persistent fever, start developing normal to low normal white count and platelet count, and their SED rate abruptly fall, they may be developing the macrophage activation syndrome. Their LDH is elevated, they can have transaminitis, they have markedly elevated ferritin, it's in many thousand, and they develop coagulopathy and fibrinogen goes low. And the concept of abrupt fall in ESR has something to do that low fibrinogen level changes the RBC sticking together, and that's why SED rate changes in these patients. So when you have a patient with systemic onset GIA that you are suspecting is developing MAS, you will do complete evaluation for infection and you would want a bone marrow biopsy to confirm the diagnosis. And another picture showing that this is the active macrophage which is engulfing the cells in the bone marrow. Before I start with the clinical feature of macrophage activation syndrome, the point I made, just systemic onset GIA with the trigger leading to MAS, also should make us aware of the controversy there, that we think some of the hematologists have discussed that treatment, they think the treatment of different kind of arthritis can itself lead to MAS, which may not be true because none of these systemic onset GIA patients are treated with TNF inhibitor unless they have burnout disease with systemic features and now they just have arthritis. Now coming to clinical features of macrophage activation syndrome, these patients mostly will present with febrile illness and they will have multiple organ involvement. You can see hepatosplenomegaly close to between 95 to 97%. They will have cytopenia among these patients 80%. Lymphadenopathy can be present in 33%. They can develop neurologic symptoms which is 33%. These neurologic symptoms seem to be a poor prognostic factor. and they can have a rash which is present in 31%. Neurologic abnormalities can be in the form of they develop encephalitis, they can develop ataxia, they can even develop seizures. These patients can be at risk of developing a syndrome called PRESS, posterior reversible encephalopathy syndrome. They will have headache, they will have altered consciousness, they will have visual disturbances, and seizure can be manifestation of PRESS. And when you examine them, they will have papilledema and they can have retinal hemorrhages. And usually their blood pressure is high at that time. These patients can also rapidly progress to have respiratory failure, and they have acute respiratory distress syndrome. And it's not unheard for rheumatologists to find these patients in ICU the first time we are getting consulted on them. They can have severe hypotension and maybe on pressors. Renal dysfunction can occur in many patients. And the studies show when these patients go into full-blown macrophage activation syndrome, the renal dysfunction can be in the form of AKI, it can be in the form of acute tubular necrosis, it can be, and they have poor prognosis with that too. They can develop hyponatremia, which is probably caused by the syndrome of inappropriate idiot mechanism. Skin lesions that they develop, they can be part of the disease as systemic onset GIA patient have their characteristic rash, or it can be because of coagulopathy, so they can have different kind of purpuric rashes. They can also have petechia because of thrombocytopenia. When you see a patient that you are suspecting that they have MAS, what is in your differential diagnosis? Thrombotic thrombocytopenic purpura, sepsis, drug reactions, and malignancy. You have to think of all those things before you start thinking that this is a patient with macrophage activation syndrome. How do you evaluate those patients? So you will start with the baseline studies, which include the CBC with differential, and you will see these patients may have anemia and thrombocytopenia. And this may occur later in the course in patients with systemic onset GIA because their white count and platelet count is very high to begin with. These patients can develop elevated liver enzyme and go into hepatic failure, as I described the case in the beginning. They can have prolonged PT-PTT and low fibrinogen and other coagulation abnormalities. And they can have very high triglyceride level. And that happens because of severe liver involvement. But this triglyceride elevation may not sometimes happen till later part of the disease. Coming to the ferritin. Ferritin level is usually greater than 10,000 in those patients who have macrophage activation syndrome. And macrophages are the primary source of ferritin in these patients. There is a very high specificity of this ferritin level in patients, in children, when they have that high level of ferritin. Now, anytime you see high ferritin in a patient, you have to have a differential in your mind, apart from if they are not in a very sick looking setting and they do not have multi-organ dysfunction and they are not having persistent fever. You know, hemochromatosis can cause that. It's a rare disease, it happens much more in men. And then patients who have transfusional hemosiderosis, patients who keep getting transfusion, they will also have high ferritin. But those patients are well known to you guys, and they include patients with sickle cell disease and patients with myelodysplastic syndrome. You will culture everything in these patients, you know, culture the blood, urine, CSF, any potentially infected body fluid, and if you got a bone marrow biopsy, then the bone marrow too. You can get different kind of viral titers and PCRs for different viruses that we discussed earlier. These patients, if they have cardiac involvement, you want to get at least a baseline EKG and chest radiograph and echo if there is a need. If they have brain involvement, you will do LP. And in patients who have the brain involvement, they can show signs of cellular pleocytosis. There may be elevated protein, and you can even see hemophagocytes in the CSF. And you would want to culture and test them for different viruses. Again, with the neurologic involvement, you may want to get a brain MRI, which can show different things. If it is PRESS, it will show vasogenic edema. It can show parameningeal infiltration if there are infections. It can just show sometimes non-specific things and subdural effusions and necrosis. You can get an abdomen ultrasound if you are not sure patient has hepatosplenomegaly. And if there is a strong suspicion of malignancy, then you will do a CT, and it will be a pan CT including neck, chest, abdomen, and pelvis. looking for possible malignancy triggering that. What kind of immunologic testing you can do in these patients? So you can look if they have elevated soluble IL-2 receptors. There is also specialized flow cytometry which is available for NK cell function and for cell surface expression of perforin granzyme B proteins. These tests are available as reference labs, and they do not help in acute setting because the results are not back right away. If you check soluble IL-2, you may get a little bit faster turnaround. You want to check the immunoglobulins because there may be the immunodeficient patient who are presenting with secondary HLH. And you also can look at the lymphocyte subset, again looking for patients with immunodeficiency diseases. So I just wanted to show you in my patient that I have sent the specialized flow cytometry for perforin granzyme B, and you can see the natural killer cells are normal here. They are giving the ranges, and this is sent to the Cincinnati Children's Hospital. It came way later after I had started treating the patient. When we get bone marrow biopsy, bone marrow aspirate should be examined and cultured for infectious organism. We should look for malignancy. Cellularity in the bone marrow may be low, may be high, may be normal. And we know that the macrophages which are present in secondary HLH and MAS, they do not have the cellular atypia associated with malignant histocytes. So if it's not a malignancy triggered HLH, then you would not see those atypical or neoplastic cell in the bone marrow. And it's very helpful to stain the bone marrow for this stain for CD163, and that stain is positive. It highlights the macrophages. And I'm showing you a report of one of my patients with HLH which had bone marrow biopsy, and it showed the positive hemophagocytosis, and it shows that there are CD163 positive histiocytes, and antibody CD163 positive in histiocytes. So this is how the bone marrow biopsy will be reported, and that's a rheumatologist's dream. We can get a bone marrow and get the diagnosis like that and treat the patient. One word of caution is sometimes you miss it, and if you get a bone marrow biopsy and it doesn't show that patient have hemophagocytosis, they may have it in their liver, they may have it in their lymph nodes, and they are very sick. You may still end up treating them, but this is something, the most easier one, the one with the less risk of bleeding, like liver biopsy is a risk of bleed, and you can do that to make the diagnosis. So in summary, when you start thinking of HLH, you start thinking of HLH or macrophage activation syndrome. Macrophage activation syndrome, you think when you know that patient already has a known rheumatology condition, and the one that we discuss is lupus and systemic onset GIA. But if it is a patient who comes with a prolonged unexplained fever, patient who has liver inflammation with elevated transaminases, and remember we check also LDH with that, and AST and ALT, patient have coagulopathy, cytopenias, and their ferritin is greater than 10,000. And why this ferritin level, I will show you 2004 diagnostic criteria for HLH, which says that ferritin greater than 500 can qualify for a patient with a 5 out of 8 criteria to make a diagnosis of HLH. Problem with ferritin is it's an acute phase reactant. We saw in other conditions it also can get elevated. It's a non-specific test still, and you see elevation, little bit of elevation up to 1300, up to 1500 in infectious conditions. I have certainly seen that level in rheumatic fever. I have seen ferritin level elevated with other infectious problems. So very high level of ferritin is when you start thinking that there is a problem. I was talking about the patient, the case I presented to a hematologist, that this patient has a 50,000 of ferritin, and what do you think about it? And his response was, anytime I have seen that high of ferritin, patient had massive hepatic necrosis. And initially this patient looked fine, but later, 2 days later, she presented with fulminant hepatic failure. And so you have to keep in mind that the level of ferritin is helpful, but the whole pattern is what you want to look when you make the diagnosis of HLH. So those patients who have multi-organ dysfunction, they're not getting well, and they have all these presentations, and they have no leukemia or lymphoma. So we keep harping on this thing again and again, but we want to get the bone marrow biopsy to rule out leukemia and lymphoma, because you will see we treat these patients with steroids. And you do not want to give steroid to somebody without knowing they do not have malignancy. You want to rule out malignancy and then use steroid. So these are the 2004 criteria. So if you get a patient that you think has HLH, if it is a young patient in infancy or childhood, or they have family history of HLH, you can check them for genetic mutation, and that alone can make that diagnosis. But if that is not the case, and this is a patient who possibly have acquired HLH or macrophage activation syndrome, you have to remember this table. Everybody of you need to know that how to look for this table. This is the diagnostic criteria, and among these 8 criteria, if your patient has 5, the chances this is a secondary HLH patient, and you have to call rheumatology, or you have to see these patients and treat them very early. Fever, splenomegaly, peripheral blood cytopenia with at least 2 of the following: hemoglobin being low, less than 9, infant less than 10, platelet count less than 100,000, absolute neutrophil count being low, high triglyceride level or low fibrinogen, hemophagocytosis in bone marrow, spleen, lymph node or liver, lower absent natural killer cell activity, ferritin greater than 500, and we discussed about that earlier. And then they can have elevated soluble CD25 or IL-2 receptor level. And if they are above 2 standard deviation for their age adjusted lab value, then you start thinking of that. So any very sick patient with persistent fevers, with multi-organ dysfunction, look at these 8 criteria, and if you can get 5 in that patient, you are dealing with a patient with secondary HLH. That's bad news. That patient needs to be treated soon. How do you treat them? You treat them with IV steroid. I made a mistake in the case that I described earlier. That patient had essential hypertension. Her blood pressure was high. I started her on oral steroid because she clinically looked really good. But then this patient presented with a full-blown MAS, and I knew that I should have started her on IV pulse steroid because she was a sick patient to begin with. So these patients, you will start with IV steroid, and when the disease gets better, you may change them to oral dose, and they may stay on the oral steroid for almost a year. You can use cyclosporin. Cyclosporin is very helpful. We don't know exact mechanism of action, but it stabilizes the lymphocytes. So those natural killer cell or those T lymphocytes which are very active, cyclosporin seem to stabilize that. So you will use steroid and you will add cyclosporin from the get-go on these patients, and the patients tend to improve with that. If there is a delay in the therapy, outcome may not be as good. Those patients who do not respond with steroid cyclosporin, then you can use other things which include the oncology protocol for HLH, which includes etoposide, dexamethasone, and these patients may need, if they have brain involvement, they even need intrathecal methotrexate. And these are the sick patients. These are the patients in which the outcome and the prognosis seems to be grim. There is some debate of using of IVIG, when to use IVIG in these patients, and there is some role of EBV triggered HLH that IVIG seem to help. My concern of using IVIG in patients with possible secondary HLH or MAS is the volume. They get a lot of volume with IVIG, and these patients, as you saw, are at risk of ARDS, and they can end up on the ventilator. So giving IVIG can be sometimes challenging. In the cases in which you are not sure, in the cases in which you are still worrying about infection, IVIG seem to be the safer choice though, because it's a pool gamma globulin from donors, and it's just passive immunity you are giving to the patient, and you are not putting them at risk if you are worrying about infection by giving steroids and other immunosuppressive. Rituximab also seem to have some benefit in patients in which you want to deplete the B lymphocyte if they have EBV triggered MAS. In lupus patients, we sometimes also tend to order plasmapheresis, which seems to help them. And again, that would not be universally applied to other conditions, so that's why I didn't put as part of the treatment for secondary HLH. Sometime when you see this patient and they have had more than one episode, or they have history of familial HLH, you have to think they will need bone marrow transplant. When would you consider it? You consider it when patients have biallelic familial HLH mutation. Remember, this is autosomal recessive disease, so that means on both allele, if there is mutation, you want to get them bone marrow transplant. If they have recurrent disease, if they have had this problem more than once, and this has high mortality, you would want them to get bone marrow transplant. If it is presenting in less than age 2, and where would you refer them? You will refer them to HLS Center of Excellence, which is in Cincinnati Children's Hospital. This is their website. This is basically talking about the diagnostic criteria of HLH. It shows the 5 mutations that they check, and they have a patient registry about all those patients with HLH and which gene is common in which ethnicity. So what are the treatment challenges in this disease? The challenges are diagnosing disease in a timely fashion. And if patients have already cytopenia and they have hepatic dysfunction, giving immunosuppression like methotrexate is hepatotoxic, and giving those medicines that we think chemotherapy medicine that usually we don't give with people with very elevated transaminases, here we may have to use them. That's the only way this patient will get better. We are always worrying that we will immunosuppress them and they may have a hidden infection. Luckily, many times when I'm involved in these cases, infectious disease have already seen the patient, extensive workup has been done, and I'm on the safer side thinking in mind that all workup have been negative and now the patient is going downhill and we need to treat with immunosuppression. We know that there is significant early mortality after diagnosis. It was greater than 20% in HLH94. I get to see at least 2 to 3 cases of macrophage activation syndrome or secondary HLH in consult on adult and pediatric side in a year. And all cases I have seen 50% mortality. So half of the cases did not have that better of an outcome. You also want to, in the challenge, think when would you do the immune testing and genetic evaluation to differentiate between primary versus secondary HLH. The reason this is a challenge because when patients present an older age with secondary HLH, they are hematologists, oncologists of the belief that you cannot find genetic mutation, because if there is a genetic mutation, secondary HLH present later in the disease and familial HLH present earlier in the disease, earlier in the age. So if you're seeing an 18-year-old or 15-year-old with HLH, there is a debate. Is there a need to do the genetic testing? Is it cost effective? And the response is that it is, because these patients can, some of these patients, because it's autosomal recessive disorder, they can even present at an older age. They can present at a later age, and then when they present, they have a very fatal disease. And this is the proof of that. This is one of a case report that I just put there from British Medical Journal, and you see this is a patient who is presenting at age 24, previously undiagnosed fatal familial HLH in a 24-year-old woman. And this is a patient with a brain involvement and a patient who did not have that good of an outcome. So we have to look for that, and we have to do the genetic mutation testing. Immunologic testing and genetic mutation testing does not help at the time of the immediate need when the patient is too sick. So we have to start treating them. But these tests we would like to do for future reference, because the patient may be at risk of developing the recurrence of the disease if they have an underlying genetic mutation. So coming to the summary, all physicians, including oncologists, ID, pediatricians, nephrologists, allergist immunologists, they need to be aware of the clinical manifestation of secondary HLH and macrophage activation syndrome. We need to know that it is aggressive and life-threatening syndrome of excessive immune activation. HLH is common in infant and young children, but it can affect patient of any age. And the take home is that genetic mutation can also present at later age with the familial HLH. Patient can have predisposing factors, and that include infections, that include malignancy, and that include rheumatologic disorder. And in any patient you have cytopenias and multi-organ dysfunction is unexplained, you should look for HLH. And it's very imperative to diagnose those patients early and start treating them as soon as possible, because once the organ damage ensues and you do not treat them on the right time, outcome may not be that good. So follow up on my case. My patient was treated with high dose of IV pulse steroid, and I added oral cyclosporin right away. Her fever resolved, her liver enzyme and coagulopathy gradually improved. Then she was later maintained on oral steroid and cyclosporin for 1 year. The steroid were gradually weaned off within first 6 months, followed by cyclosporin during the next 6 months. Her flow cytometry showed normal NK cell function for perforin and granzyme. Her genetic testing, this was African American patient, was negative for PRF1 mutation. This patient is asymptomatic for last 2 years, and she is being followed in my clinic for 6 months. These are pictures of my patients from the annual Juvenile Arthritis Day that we do with Arthritis Foundation. And I'll be happy to answer any questions.
It's a great presentation. Thank you very much. Questions?
Very good presentation, number one. You know, we neonatologists, just a joke, first of all. I mean, going to lighten up this talk. MS, we neonatologists call memory aspiration syndrome. HLH, we call hypoplastic left heart. So my question is, you know, there's a lot of data on SLE and pregnancy, perinatal outcome, neonatal outcome. Is there anything in other primary MAS that people have looked at, because you said there's specific genes in certain populations? Have they studied that? Since it's an autosomal recessive, so you've got 1 in 4 chance of getting it in some things.
Well, I think if you find a patient with familial mutation, you would want that family to get genetic counseling and other people to get checked for that. How much data is there, I'm not aware of, but I know that if a patient presents at a very young age, an infant or a child you're seeing with HLH, there has to be genetic counseling of that family, and parents have to also need to be looked at and make sure that none of them have the mutation, because they have to have the mutation. That's why, but if sometimes they don't have biallelic mutation, that's why none of the other family members have presented with the condition and one sporadic case arises, and with that you start recognizing the need that this whole family would need a genetic counseling and be looked at for that. I hope that answers the question.
Yeah, because you emphasize on the early recognition. Thanks.
Yes.
You guys said that anakinra, the IL-1 antagonist you use for arthritis patients who have MAS, but do you have any experience using it because of the general inflammation it causes by IL-1 in non-arthritis patients who have HLH? Do you know any reports of using it?
I think people have used it, and I think anakinra is a safe medicine. It's been used in people with septic shock in ICU. Anakinra, the doses up to 10 milligram per kg per day have been used to successfully resolve macrophage activation syndrome. When patients come with a known diagnosis of systemic onset GIA or lupus and have macrophage activation syndrome, life is easier because we already know that's the thing which is causing the problem. But there are patients like the patient I presented, she possibly have systemic onset GIA, but she did not develop. 1/3 cases of systemic onset GIA may be delayed in presenting with arthritis. I have had one patient referred to me from oncology, Oncology Rheumatology clinic, and that patient has a history of rashes, fevers, lymphadenopathy, and hepatosplenomegaly, and ferritin was 15,000. And that is a systemic onset GIA patient. I started treating with anakinra, all symptoms resolved. His lymphadenopathy, he was scheduled for a lymph node biopsy, and by the time he went for the biopsy, lymph nodes have resolved after starting anakinra therapy. So it does help patient with MAS, and it can be used in those patients in that setting, especially if they have a known rheumatology condition. It's easier to obtain the drug and use it compared to if somebody does not have the known diagnosis. Then your choices may be then the medicines we use like steroid and cyclosporin, the one we discussed. I have seen my first case of, I was telling Dr. Buchini, my first case of macrophage activation syndrome was the case which made me do Peds Rheumatology Fellowship, because that was the most sick patient I've ever seen. She was 3 years of age with systemic onset GIA, and she had started developing leukopenia, and her IgE level was checked, which was high. And we know that if you check IgE level in systemic onset GIA patient, they are usually high. So the mistake which was made is her anakinra was held, thinking that she's developing drug problem, and drug is causing leukopenia and IgE elevation. And that led the patient disease to be more rampant, and she developed full-blown macrophage activation syndrome. So she not only had cytopenia, she had seizures, she had acute renal failure, she was treated with steroid and cyclosporin, and later with etoposide and the HLH full protocol, but the patient still did not have a good outcome. So I feel that that patient, if would have been continued on anakinra, things would be different. So controlling inflammation with anakinra is one of a helpful thing in patient with MAS, if we can do in patients. But when patients have far advanced disease, then steroid and cyclosporin seem to do the better job.
All right. No other questions? Again, thank you very much.
Thank you.